please. Okay. Good evening, everyone. I'm Dr. Abbas from medical team of Sun Pharma. It gives me a great pleasure to extend to you all a very warm welcome on the behalf of Sun Pharma for today's webinar on the topic full mouth implant rehabilitation. At Sun Pharma, we believe in connecting eminent faculties from around the world for exchanging their skill and experiences with each other, which in turn benefit the patient. Today's webinar is one of these such events. With this idea, I take this opportunity to welcome today's speaker, Dr. Tarun Kumar. Dr. Tarun Kumar is considered one of the leading authority in bone regeneration. He is formally trained in periodontics at Rajiv Gandhi University of Health Sciences. He is extensively worldwide and published over 50 articles and book chapters. He was the assistant editor, International Journal of Oral Implantology and Clinical Research. He is on several editorial boards for scientific journals and presents, and he is a well-published author who has lectured extensively on dental implants. And over to you for the talk, sir.
Thank you, Abbas, and it's an honor to be here. And thanks to whole of Sun Pharma team for organizing this webinars in these crazy times when we all require, something to sharpen our axe by increasing our knowledge in the clinical skill level. So I will going to start my lecture today. Can you confirm that the screen is on?
Hello, sir. Yeah. The screen is not visible. Yeah, it's visible. It's visible, sir.
It's visible.
No, sir. You have shared a different screen. Please open your presentation and you share that. You share a different screen, sir. You open the presentation and please share that. Yeah. It is visible now, sir. It just came and just left.
I think it's not showing off to me.
Yeah. It's not visible, sir.
Even here it is. Here it is not visible. Give me a second. Probably
yeah.
Will come on. Yeah, even my this thing it is not seen. Wait for the screen to come up. I might have to restart the whole thing. Okay, I think it's not. I will restart my.
It has come, sir. It has come.
It has come, doctor.
Okay, now yes. It is there, I think.
Perfect.
Yeah.
Perfect, sir.
Okay,
Go ahead.
let's get cracking. Today's topic is full mouth implant rehabilitation. As Dr. Abbas has given my introduction, I am Tarun Kumar. I work at Bapuji Dental College and Hospital at Bapuji Implant Center, which is one of the affiliate bodies of International Congress of Oral Implantology. And this Bapuji Dental College is in a small town called Davangere, which is in Karnataka, in southern part of India. Now, today we are going to see how we are going to treat edentulous patients or terminal dentition, which is going to be converted into an implant retained restorations. Because we are going to see in our country, especially, we see various age group of patients requiring this kind of treatment because of disease issues with the teeth, especially periodontal disease affecting younger population, requiring a full mouth rehabilitation of the patients. Now, if you see in this particular screen, you will see from a tender age of 25 years, where there is some syndrome where all the teeth are missing. Even in such case, we need to do a full mouth implant rehabilitation to give her the confidence what is required to see the future life of us. And in the middle of the screen, you will see an edentulous patient who is already 65 to 70 years, who comes to us to get a restoration wherein we can plan to have a implant retained restorations. And sometimes you will see patients who are in terminal dentitions, what you see in the right hand side, where we need to slowly get converted so that they move from a terminal dentition to a fixed restoration, which is supported by implants. When we talk about treating edentulous patients, it is more of collaborative work or a team work, and I am blessed to have a very good team which has oral surgeon, prosthodontist, and periodontist along with me, who is working in my implant center. And along with that, the most important component in collaborative work is our lab technicians. And we do work with multiple labs, especially Katara Dental Lab and VIP Dental Lab. We are working with them to do all these cases, what you will be seeing in this presentation. Now, before I begin, I would like to say these great words by Sir Winston Churchill. He said, "He who fails to plan is planning to fail." That means if you don't plan your case, especially these kind of full mouth rehabilitation patients, you will end up having failure in your treatment. So it is all about planning the case. How you are going to plan a case depending on the situation of the patient, depending on various factors which we will discuss, which is existing in a patient. Taking care of all of these things, we are going to plan how we are going to treat such patients. Whether it is an edentulous patient, completely edentulous when they come to us, or a patient which has dentition in terminal stage, where we need to forego all those teeth and place implants and restore that patients. Now there are various kind of treatment what you can do for a full mouth rehabilitation, from a simple overdenture retained overdentures can be done on a mandible or maxilla, or it can be actually placed implant, 4 implants, 6 implant or 8 implants, and you can give a fixed restoration. Or sometimes when there is not sufficient bone, we might do what you see in the lower left quadrant, all on 4 treatment. Or in some cases where there is very atrophic maxilla, we might have to do something called a zygomatic implant and restore such patients. So we will go and see what patients, what kind of treatment planning we are going to do, and what are the things we need to keep in mind when we are treating such patients. Now, one of the factors what you need to keep in mind is the age of the patient. We are going to get patients from different ages, right from a tender age of 25 years old to a patient who is 80 or 90-year-old. So your treatment plan depends on the age of the patient, because a young patient always desire to have a fixed treatment option, and also he will demand for more cosmetic or aesthetically driven restoration. Whereas a 80 to 90-year-old patient would rather like to have some function to their prosthesis or the restoration. And in such cases, I would not do a high morbidity procedures wherein I would like to go and do a sinus graft and restore such patient with high morbidity surgical procedures. Rather, I will do a simplified treatment plan because they are going to have a few years where they need to enjoy their life and enjoy their functional teeth. Now, one of the most important thing you need to analyze when you see a completely edentulous patient is the amount of bone available. Now, depending on the bone available, you will decide what kind of restoration you will give. Now, there is a very, very popular classification which is given by Carl Misch, which is almost all the courses they teach you about this classification FP1, FP2, and FP3 type of restoration. Now, these type of restoration depends on how much bone resorption has occurred. If you have no resorption and you are going to restore such an edentulous patient, which is a very, very rare scenario. In such cases, you will end up giving an FP1 restoration. That means there is only crown which will come and there is no replacing gingiva which is going to come, or bone or soft tissue will not be replaced in such a restoration. Most of the time, what we see is mild resorption or moderate resorption patients. Even in cases of terminal dentition, most of the terminal dentition comes to us because there is periodontal disease. And when the periodontal disease destroys the bone or resorbs the bone, you will end up having mild to moderate resorption. But in certain cases, you will have aggressive disease process where we will have advanced resorption, and because of which you might end up giving an FP3 prosthesis. And also in advanced resorption cases, we might be doing something called as zygomatic implants. Now, the bone zones, especially in the maxilla, what we have is divided by Bedrosian classification into 3 zones. Zone 1 is the premaxillary bone, where usually we find good amount of vertical height of bone, but sometimes you may not have the sufficient buccolingual width of bone. Zone 2 is the premolar zone, where sometimes the posterior sinus is limited. The sinus is limited. In such case, you can go ahead and place implant in these zones. And zone 3 is the molar zone, which is most complicated zone because that is where the sinus is always pneumatized in an edentulous patient. And whenever we see a patient, we will always observe for this zone whether we have bone in all the zones or we have bone in zone 1 and 2 only, because our treatment plan depends on how much available bone is there in the maxilla. Whereas in the mandible, the limitation is basically in the posterior mandible. As you go behind the mental foramen, the chances of having vertical height of bone is less. But today, even if you have minimal height of bone, we have short implants which can be placed and restored, which can be connected with the anterior implants, and we can do a full arch fixed restorations. Now, one thing we need to analyze when it comes to the soft tissue of the face is the lip dynamics. Every patient will have different lip dynamics. Some patients show off a high smile line, some patients show off only the teeth, and some patient doesn't show anything. So you need to analyze what kind of patient you are dealing with, because that will decide what kind of restoration, what type of restoration you are going to do. Now, coming to the number of implants, what you're going to place. What is the magic number? We're going to place an 8 implant in the maxilla, or it is a 6 implant in the maxilla, or 4 implants in the maxilla. Or in the mandible, whether you're placing 6, 5, or 4. But what is the magic number? It depends on many things. It depends on the bone available. It depends on the age of the patient. For example, if I am treating a young patient, I would always like to have more number of implants, and I would like to place axially placed implants, because the moment I go for angulated implants, the chances, if there is some kind of disease happening and if I lose an implant, the chances of repeating implant therapy and giving a new restoration becomes less. And especially patients who are in their 30s or 40s, if I am placing less number of implant and tilted implant, And after 20 years, she comes back with one implant failure. We will not have sufficient bone to work around to place another implant and give restoration. So we need to consider multiple things when we arrive at this magic number. Many of the people get carried away by saying, oh, all on four philosophy. Now, all on four philosophy or all on six philosophy is basically a philosophy treatment modality when you do not have sufficient bone. So you need to analyze multiple things before you conclude what type of patient you are treating, what is the age of the patient, what is the amount of resorption of bone patient is having, what kind of lip dynamics the patient has, everything. The second thing what we need to analyze is what type of prosthesis is required, whether you are doing an overdenture patient or a fixed restoration. Now, if it is overdenture, if a patient is 85 or 90 years and the mandibular denture is complaining of mandibular denture which is loose and unstable, what I would do is a simple overdenture with in the mandible with two implants with a ball abutment. Sometimes, if economical situation is there or a financial situation is there from the patient side, even a single implant in the mandible in the center line and giving overdentures helps them and reduces their the instability of the denture. In the fixed restoration, you have different types. You have hybrid restoration, which is basically your acrylic teeth with a metal, also called as wraparound denture, where you have a metal framework. Around that, you have a acrylic restoration. Or you have porcelain fused to metal. You have PFC restorations, that is porcelain fused to zirconia restoration. And these days, we have something called as peak restoration, which is slowly catching up, but it is a restoration which probably will have a lot of future value because this restoration reduces the weight of the restoration. That we will discuss later. Now, if you're placing implants, whether you're placing axial implants, tilted implants, or a zygomatic implant, it all depends on how much bone which the patient is having. Or you're going for a delayed loading option or immediate loading. If we are doing an immediate loading or delayed loading, are we giving a provisional restoration? Whether the provisional restoration is a removable restoration or a fixed restoration. If we are doing an immediate loading, we are going to go for, most often, we are going to go for a fixed acrylic restoration, which is a denture conversion method, what we are following. And ultimately, sometimes we will think whether we need to do some augmentation. Sometimes in some patients, if it is a young patient, I would rather go and do augmentation. I will stage the procedure in such patient where I will place some anterior implant, give her an implant-supported denture initially, do the sinus grafting, later on convert that patient into a full fixed restoration, because when I have more number of implants well distributed along the arch, it will serve longer. That is what we have learned from the literature. Now, coming to the various types of overdenture, what you can deliver for the patient, especially a patient who is just complaining of loose dentures. This is one of the best option what we have, and this is one of the most satisfying to the patient because we can just place the implant on the same day. We can do a temporary pickup of the denture with the ball attachment or the various attachment we have, and the patient goes up back immediately from the clinic, well, very, very satisfied because his denture immediately becomes retentive. And we have different options for overdenture, from the ball to locator attachment to the magnetic attachment, depending on how much prosthetic space we have. Now, all this restoration depends on how much prosthetic space we have. If you can give a ball abutment, whether it is a locator attachment or a bar attachment like this, what you're seeing here. Now, all the time, it is not necessary and it is not mandatory that we need to do a fixed restoration, because in some patients, when the facial soft tissue dynamics is such that it requires some lip support, we might end up, even by giving more number of implants or zygomatic implants in this case, we might end up giving an overdenture because the flanges can be used to support the lip and give a better aesthetic facial appearance. Now, let us see a case, and now we will go through different case reports and see how we are going to treat these patients. Now, we will see this patient. This patient has adequate amount of bone in A and B region and a little bit of sinus encroachment in the B region. So what we can do is, in a young patient like this, what we can do is do simultaneous implant placement and along with that plan to do a sinus grafting. So in such patients, when we are doing multiple implants, 6 to 8 implants in place, what we'll have is good stability of this implants and the restoration gets cross or splinted. Even then we can do immediate loading of such patients. Now, if you see a different type of prosthesis which is available to us, which is fixed restoration, we will have a prosthesis like this, which is what we discuss overdenture, or it can be a fixed restoration like what you see, a PFM restoration, porcelain fused to metal, or a porcelain fused to zirconia restoration. Now, what type of restoration you will choose depends on how much prosthetic space is available for you. And there is a very good classification or a guideline given by our good friends, Dr. Ali Tunkiwala and Udatta Kher from Mumbai, where they have described or given a guideline depending on the vertical space or the restorative space available. If you have a restorative space of 10 to 12 millimeter, what you can do is a PFM restoration without, it is an FP1 restoration, what you can see here, where we are not given any gingiva, we have just used a screw retained bridge on the implants. And if it is 12 to 15, then we give a PFM with pink attached to that. And for 15 to 18 millimeters, then we might have to go for a hybrid restoration because the weight of the restoration increases. And this is where the new material like PEEK will help. The restoration, what you're seeing here on the lower end is a PEEK restoration, which is a bio-HPP restoration, where you can see because of the framework is very less weight, you can go in for such a larger vertical space availability when there is large prosthetic space available. So let's see this case one, which I described, the CBCT scan. And the most important, the how much is the transition zone. When the patient smiles, you need to see the transition zone, that is the edentulous ridge, whether he is showing his edentulous ridge. We will discuss about that after we discuss the case. And in the posterior extent, as I showed you in the CBCT, I'm going to do some sinus lift. Today we have few sinus drills which can be used to create lateral window and do a sinus lift procedure. I go ahead in the posterior region where there is minimal bone. I do the sinus lift procedure. And in the anterior portion where I have sufficient vertical height, I'm going to use a drilling protocol which is called as osteodensification protocol, which is used with the denser drills. These are new type of drills which will densify the bone. So when you densify the bone and you place the implant, your stability, primary stability of the implant is very good. Because your primary stability is good, we can go for immediate loading in such cases. And whenever we plan to do an immediate loading, we always would like to have good primary stability of our implants. So this is a drilling protocol we follow in the last 3 to 4 years for all our patients, where we want to, especially in the maxilla, where we want to get good stability so that we can immediately load or do a denture conversion for our patients. Now, one more important thing you need to see here is when I am placing my implants, especially in the maxilla, my implant should be more palatally placed than in the middle of the crest. So that is why what I do is I place a paralleling pin into the nasopalatine canal. Now, nasopalatine canal is relatively palatally placed, and because of which, if you use that as a guideline, all my osteotomies will become more palatally placed. And why we need to do this is basically because the maxilla resorbs in a downward direction, and it reverts in a backward direction. So what happens is basically your buccal plate starts resorbing, and when it resorbs on a long term, what happens is your implant starts getting exposed, and the patient will start having metal exposure, and subsequently there might be recession on the implant showing of the implant surface, which might ultimately lead in peri-implantitis. So that is why we place our implant as palatally as possible. And you can see here on the posterior area where my posterior implant is going inside. I have already done the grafting in the sinus, and I am placing my implant. And my implant, all my implants receive a very good stability of more than 68 ISQ. I always check ISQ values before I load my implant. If we are doing multiple implant, even a 67, 68 ISQ value is good enough to load immediately. Now, again, if you see, I have kept the paddling pen and using that as a guidance to place my implants. This is the other side of the same patient. Again, using osteodensification to place the implants, the denser drills, densifying the soft bone and placing the implant. Now, after placing these implants, what we need to analyze is, do we have sufficient buccal bone? On the day of implant, you might see, okay, there is covering of bone. It is not just covering of bone. You need to have at least 3 millimeters of bone buccal to your implant. If you not have that, you need to do contour augmentation or a veneer grafting procedure in such cases. So what we do is, since we have very good stability, we can place our multi-unit abutment. Now, multi-unit, the choice of using multi-unit is again dependent how much of vertical space you have. If you have good vertical space or restorative space available, you can go for multi-unit abutments. If not, then it is better to go for a customized abutment solutions. Another thing, what I have learned from my experience is these multi-unit prosthetic screws are very small, and especially if the patient is having bruxism or such issues when the teeth, when especially patients who you are transitioning the teeth to implant, you will see that there is a lot of attrition and there is a lot of wear facet. In such cases, I would still prefer not to use this multi-unit, because I have seen that in such patient there is a lot of screw breakage which occurs with this multi-unit screws. So what we do is, since we don't have that 3 buccal bone over the implants, we just take some graft material. In this case, it is alloplastic graft, which is mixed with platelet-rich fibrin. And I use it as a veneer grafting material. So I mix it with some autogenous bone, which can be scraped from the exposed bone. And then you layer it on top of the implants, which doesn't have sufficient thickness of buccal bone. Now that is important. Many of the younger generation, when they place implant, they will just see, okay, there is some amount of bone and the bone is covering. I didn't have to worry. Now you need to think that once implant is placed and you just have 1 millimeter or less than 1 millimeter bone covering it, the vascularity in that area reduces, because of which on the longer term, as the maxilla resorbs, your implants get exposed on the labial side. So we always need to build bone when we have less than 1 bone on the buccal side, even in a completely edentulous situation. So we placed implants, grafted, and put some collagen barriers on top of that graft material, and we suture the flaps. And you will see that the multi-unit screws are exposed when we suture the flap, and we use the temporary abutments on the multi-units, and we do a denture conversion for the patient. So we do the same day, pickup of the denture, and this is one of the most important guide what we will have, the temporary or the provisional restoration. Now again, we can, if our provisional restoration is perfect when it comes to aesthetics and occlusion and the vertical dimension or the vertical relation of the patient, we can use this temporary restoration to the lab to provide us, which is exactly similar to this temporary restoration, and then we don't have to go for multiple steps of verification when we go for the final restoration. And again, Udata and Ali has given the beautiful article on this particular technique, which is called as fast tracking. People who are interested can go through this article where we how to use the provisional restoration to fast track the final restoration. For the lower arch of the same patient, you can see the ulnar bone in the anterior zone and in the crestal part is very, very thin. So in such scenarios, what we usually do is do a crestotomy to remove a little bit of crestotomy to remove thin bone. And once we have sufficiently wide, thick bone, we do our implant placement. Again, as I told, we need to have at least 2 to 3 millimeters of buccal bone present. And especially in mandible, since it is highly cortical and the resorption is not similar to what we see in maxilla, so a little bit of less bone in the mandible, still you get away, but in the maxilla, you need to do a grafting procedure when you have less bone. So again, what we do is a procedure you can see here. In the mandible, what problem we face is a lack of keratinized tissue around implants. So when we suture it all over, the keratinized tissue, since you have done a bone reduction, you have done a crestotomy, what was attached to the bone now becomes free because your keratinized tissue now is not in relation to the bone. So what happens is this keratinized tissue starts resorbing, and ultimately, when everything heals up, you will not have keratinized tissue. It is only the annular mucosa which is there. So these days, what I do is to preserve that keratinized tissue, I preserve it by using these soft tissue screws, which is available from a company called as Pioneer. So we can use these screws to hold soft tissue onto the bone so that you don't have to, when you suture, the keratinized tissue will not come over and go away from the bone, and because of which you lose the keratinized tissue. So this is one of the techniques what I am using. The other technique is suturing the soft tissue to the bone. So we can use that technique also, where we can suture the soft tissue to the bone so that the soft tissue gets over onto the bone, and without having support of the bone, it resorbs. So this is after the healing of the soft tissue. After 4 months, we go for the final restorations once we have removed the conversion dentures, and we can use the same conversion denture to take our final cast. So if the fitting is good, we can use that, and you can use the putty index to send it to the lab so that they make the final restoration exactly same like the provisional restoration. So this is how the temporary provisional restoration looked, and this is how the healing of the final after we take out the provisional restoration looks. And you can see the amount of keratinized tissue we have on the buccal side. We have very good bone, we have very good soft tissue. That is what is required for long-term maintenance of the implants and restorations. So this is how the patient looks. This is how the final hybrid restoration looks. This is a hybrid, that is a wraparound restoration, where there is a metal framework on which there is we can use a composite teeth or an acrylic teeth and acrylic denture material. Now, the problem with this kind of hybrid restoration is there is slow, resorption, or it starts dissolving the acrylic, and underneath this denture, there is a lot of food accumulation. And gradually, what happens is, as the year go by, there is a lot of attrition of the teeth, and the underneath surface of the intalgia surface of the denture become rough, and it starts accumulating plaque. And further, if it is left unclean, it might lead to peri-implantitis. So what we usually do is, when we give such a kind of restoration, it is told to the patient that every 1 year we need to remove this is a screw retain restoration, so you can unscrew the restoration, remove it, clean it, polish it, and put it back. And that is the reason why we shift away from this kind of hybrid restoration to a material which is much more stable, which is a peak restoration or a peak framework, which is wrapped around with a composite, which is a composite which will not easily degrade like acrylic. So this is the final X-ray of the patient. You can see 7 implants being placed in the maxilla with sinus lifts. And we have given a fixed restoration to this patient. Now we will talk about transition zone. What is this transition zone? Transition zone is that zone where when the patient smiles without the teeth, or when the patient is wearing a denture which is fabricated and patient smiles, you should be seeing only the teeth or you should be seeing the gingiva of the acrylic denture what you have made. If the patient shows the gingiva which is existing as well as the gingiva which is marked in this as red color, that means when the final restoration comes, the patient is going to show the patient gingiva, the prosthetic gingiva, and the teeth. So what happens is basically it is very difficult, especially in Indian scenario where we have melanin pigmentation. It is very difficult to match the patient gingiva to the gingiva which comes in the restoration. So it is always better in such cases we do a little bit of crestotomy so that whatever is seen is either pink of the restoration or it is the pink of the patient. So we don't have half of pink of the patient and half of pink of the restoration. So in this case, if you see, only the anterior part of the maxilla is having a lot of bone, and as it goes posteriorly from the canine region, it is resolved. So what happens is when you give a restoration, if you do a restoration on this area, you will see that you will have some pink of the restoration, some pink of the patient, and as it goes posteriorly, you require to build soft tissue with your pink prosthesis. And this will create a mismatch and you will not get a restoration in a single plane. So it is always better to have a restoration in single plane so that it is easier for the patient for the maintenance also. So in such cases, we need to talk about doing a bone reduction technique. Now, if you see this patient, two different patients who have been restored with implant restoration, if you see this patient on the top, you will see that she has a high smile line, which is showing off the pink of the restoration, what we have done. If you see the patient on the down here, what you can see is a patient with a low smile line. Even if he smiles fully, he is showing only the middle third of the teeth. That means the gingival component is not really seen. In such patient, it is okay to, if you have in one single plane, you can do restoration what you feel like, because it really doesn't matter because it doesn't show up. So you need to, when we think of doing a prosthesis, we need to think of all these things and do the treatment plan accordingly. Now let us see a case which is a transitional case. That means patient is in a terminal dentition, which is completely not savable or salvageable, and we need to convert her from this situation to a full mouth implant retained fixed restoration. So you can see her teeth, it's in all places. There is periodontal disease, migration, there is, because of breath, there is some kind of occlusal issues, and because of which there is a lot of bone loss which has taken place. So what we do is basically we extract the teeth because it is periodontal disease. It is always a good idea to remove the disease first before we place implant. So what I do is first extract teeth, degranulate that sites very thoroughly with lot of irrigations, and we sometimes give tetracycline packs or collagen with tetracycline into the socket so that all the infection in the gums is reduced when we go and place implant. So this way we wait for 6 to 8 weeks for the soft tissue to heal and all the disease to get eliminated. And in the interim time, what we do is an immediate denture for the patient so that the patient goes away with a temporary denture, especially a young patient like this. So once temporary denture is ready, what we do also is duplication of that temporary. If the fit is fine, if the aesthetics is fine, we duplicate it so that we can use it as a radiographic stent. You can see here in this duplicated denture, there are certain radio-opaque markers which can be used when you put it inside the patient and send him for a CT scan, we will exactly know the position and from the denture's perspective, as well as when we do a computer guided planning, this can be correlated and the CBCT can be matched with the denture what we are placing in the scan. So here we are not doing a guided surgery, we are doing a freehand surgery. So we are going to use that same radio opaque stent what we manufacture, which is a duplicated transparent stent. We open it up and place the implant according to the position of the teeth what is seen. And once we place this, we end up doing some kind of sinus grafting in the posterior because the sinus wall was less. It was pneumatized, and in the anterior zone, we had sufficient bone. We just had to do a little bit of contour augmentation. And something similar we did in the lower also for the patient. We placed sufficient number of implants, and you can see here lower 7 implants, and upper also we have 7 to 8 implants with the sinus lift on both the posterior most implants. So both nearing this region of 6 we have implants. So there will be not much requirement of having a big cantilever in this patient. And here you can see we do a staged process here. We wait for 2 months for the implants to get integrated, come back. And again, during the procedure, one of the most important thing we need to take care is managing the soft tissue. So here what we are going to do is manage that soft tissue by buccally displacing some of the keratinous tissue from the palatal side onto the buccal side. And because of that, you will see that in the next slide, when it heals, you have a beautiful soft tissue, keratinous tissue, thickness of the soft tissue, everything which is achieved. Now, after the surgical procedure, again, as I told, it is a teamwork. My friend, who was the restorative dentist in this case, Dr. Raghunandan, did the restoration. This is the process of the restoration, what we did. So what we are doing here is doing a special tray according to where the implant is placed. Then once the primary impression is done, the lab sends a jig. And once we do the jig trial, that is to check if the primary impression is right or wrong. If there is any issues with that, we split this jig, reattach it, and do another impression, which will be the final impression. Now, all these things can be avoided if you do a provisional fixed restoration, which can skip all the steps, as I told before. So again, you can see jig trial. We are doing a splitting of the jig if it is not passive, and reattaching and taking the re-impression and sending it to the lab, and finally the final cast is derived. And from there on, we do the jaw relations with the right aesthetics, what is required for the patient. And once everything is done, the patient, the lab does putty index of that denture, and then finally does the framework. In this case, it was a porcelain fused to metal, what we call it as a polymolar design, where we have a framework separately and individual crowns or a bridge which is cemented on the teeth. Now, the most important thing, especially when you have implants at a trajectory which is slightly labial, especially in the maxilla, you want to have such kind of restoration where the screw hole is coming labial. And in such case, if you have cement retained individual crowns, in case there is a screw loosening, we can take out that crown, tighten the screw, and replace that crown. So that is the advantage of doing this kind of restoration. So this is, you can see on top, it is a maxilla where it is a polymolar bridge type, where there is separate framework, and on top of which we will place the ceramic crowns. This is how the final outcome of this restoration is. And lower is a full arch fixed restoration. And you can see pink ceramic, which is layered on top of it. And this is how it looks on the patient's mouth. And you can see when the patient smiles, she shows the restorative pink, not the pink of her ginger. And this is 2-year post-op, where you can see nice, beautiful healing of the areas where we have grafted. We have sufficient number of implant, which is doing very well. And that is the great advantage of doing multiple implants in actually place good number of implants in young patients. Now, one of the cases which is very attached or very near to your heart is this particular patient, which myself and Dr. Narayan treated. She was coming to Davangere for the treatment for the initial period. Then she got relocated to Bangalore. So I transferred this patient to a very good friend and a superb clinician, Dr. Narayan, for the restorative work. Now, this patient who reported to us when she was 13 years old, and she had been diagnosed as a Cruzon syndrome patient with all the teeth which was impacted inside her jaws. And we could see in the OPG that most of her teeth in the anterior were completely impacted. We tried waiting, doing orthodontic, nothing worked because it was internally ankylosed, and orthodontist couldn't pull it over. So finally, we decided to do a denture for her till the time she comes 18 years. And then what we did by the time, this is how it looked. No, none of the teeth had come out or changed anyway. And then we decided to extract this teeth. Now, extracting such teeth means we are going to lose that much of bone because we are going to do disimpaction procedure. So all these procedures were planned in such a way that we will not lose as much as bone. We will try to regenerate bone. So we went ahead, extracted all those impacted teeth. This is how it came out. And you can see there's a large defect which was created because of the angulation of the tooth roots which was there. And we went for the grafting procedure. We filled all the socket with graft, used titanium mesh to reconstruct all the labial plate which was missing. This is the upper, where again you can see the kind of dilaceration patient had, probably because of which the tooth never, couldn't be moved orthodontically. And we removed all the soft tissue. You need to be very careful when you are taking out such impacted teeth. You need to remove all those soft tissue, and went ahead, grafted that upper. This is how it looks, the healing. And when she came back after 6 months, we went ahead. We had good quality of bone which is formed. We could place implants in the upper, and send. By the time she shifted to Bangalore, and I handed it to this great man, Narayan, and he took it over from me and did this restoration for me, for this patient. This is how she looked. She wanted high aesthetic demand, especially young patient, but her lower had a lack of keratinized tissue, and we decided to have something removable which can be cleansable in that area. For upper, we decided to give a fixed restoration. So again, we decided in this case we had to go for a zirconia framework with Emax crown for aesthetic purpose, and this is how it looked. For lower, we gave a telescopic denture on the implants, and this is where we started, and this is where we ended in this restoration. And you can see the smile we have reached from where we started to where we ended. Of course, as I told, the teamwork is the most important component in such cases to treat successfully. Other cases, again, a young patient, terminally diseased dentition, periodontal disease, aggressive disease, all her tooth has been in a very bad state. We need to remove it. We removed it, waited for some of the disease process to stop, and this is how it looked after all the teeth was removed. And then we went ahead and started doing restoration. And you can see how thin the soft tissue and bone looks. And this is how exactly it looked. The anterior bone was so thin, we didn't have any sufficient bone to place implant in the anterior except in this region. This is where we used our main fulcrum implant in the anterior. So we went ahead, we placed the nasopalatine canal implant. We removed all the contents of the nasopalatine canal. We cleaned it up, and we placed implant in that region. And in the posterior, we had good vertical height. There was no sinus, and we could place a good number of implants. We placed as many implants as possible because the bone was very soft. We even went on one side. I placed a pterygoid implant. If at all there is a loss of any implant, we could have an implant which can be used. That was a pterygoid implant. For the anterior, we did some grafting process to build that bone so that soft tissue will be supported, and we closed it. And in the lower, we did the same thing. Used the denture, did some prestotomy, placed implants. This is the metal trial. This is a PFM crowns, what we did, and this is the final restoration, what we gave to the patient. Now, you can see this is how the PFM restoration looks, and this is how the smile looks of the patient, a young, happy patient, what we have, especially their confidence for the life in future is great when you have patients who really appreciate your clinical work, what you do for them in such patients. So you can see in that 2 pterygoid and implants have been placed, and which has not been connected because the other implant was very stable, so we didn't want to extend the framework at this point of time, but it is still left inside as a if at all there is failure of any implant in future, since she is young, we still have two implants which is totally integrated in the bone, which can be used. So this is how she looked when we left our office. Other case again in our 50s, where you can see this is how when she smiles, she doesn't show the gingiva. That means it is a safe case to handle. And you see this, the posterior has some bone, but not full bone, complete height of bone, what is available. But we can still do some crustal sinus lift and place implants in that area. So we go ahead and you can see the soft tissue. This is how this lower has been treated. We place the implants, as many implants as possible in the lower, three implants on either side. And what we do also is when we are treating, we take some keratinized tissue from the upper edentulous arch, only the 2 millimeter thickness, deepithelize it and use it as a connective tissue on the buccal side of the lower implants, so that we develop good amount of keratinized and volume of tissue over the lower implants. Because I told you earlier, the problem with lower implants is peri-implantitis in the implants which is placed in the anterior zone because of lack of keratinized tissue. To avoid that, we did that, and 2 weeks later, when the patient came for upper, you can see beautiful soft tissue has again reformed. We used the denture, and you can see through the denture, we placed our pilot holes, and then we go ahead and open the flap, and you can again see, as I told in the earlier cases, I am using this paneling pin in the mesopalatine canal, and I'm going to drill all these osteotomies using osteodensification concept, and as a reference, I am keeping this paneling pin so that my implant goes as palatal as possible. So we go ahead, do crustal sinus lift on the posterior using osteodensification, that is minimally invasive transcrustal sinus augmentation, not doing a lateral here, grafting the sinus through that osteotomy itself, and putting as many implants as possible in the maxilla. Okay, and place implants wherever there is posterior good width of bone. In the anterior, we thought that if any of the posterior implant fail, we might require more bone to place implants. So we use some allogenic blocks to build the anterior bone too, so that it will, when we come back for doing the final restoration, we will have good support for the soft tissue, as well as if we require, we can use to place implant. But thankfully, none of the implant failed. But when we removed it to take some histology, there was good bone formation and we had good soft tissue in that region. So what kind of restoration we did here was a peak framework. As I told, when you imagine if the restoration is going to be very heavy, you can go for this new material, even though we don't have sufficient literature, but we have 5 years of follow-up of our own cases, which is showing good results without any problem. So this is peak final restoration, which is placed onto the patient's mouth. And this is the final OPG of the patient. This is how she looks, and you can see that smile tells everything of the patient, the confidence she has developed from the time she has been edentulous to the time we have restored her. That smile tells everything. Now let us see other concept of tilted implants, where we are calling it as all-on-4, when we don't have sufficient bone in the two zones, that is the premolar zone and the molar zone. We sometimes end up doing these procedures. And you can see in this patient is a patient who is already 60 years old. Periodontal disease, we need to eliminate all those teeth. At this stage, we take out all this teeth. But now these teeth are not going to the dustbin as you think. These teeth can be used as graft material, because dentin has been proven to be a very good graft material because it has collagen in it and it has osteoinductive factors, and it can act as a good bone graft material. So I use it, clean it. We have a dentin grinder. We grind it and preserve it to be used on the same patient. So patient comes back after some time of healing when the disease is completely resolved. That is what I do. You can see that collagen impregnated with tetracycline placed inside the socket, and I give a temporary denture for her till the disease is eliminated. She comes back and then we reflect a full thickness flap, you can see how far palatally our implant goes. This is where the teeth was, this is where the socket is, and this is where my implant is. This is what I was doing. Place the implant palatal to the sockets. And again, as I said, we want good quality of bone on the buccal side. We have placed whatever dentin bone graft we grinded, we are going to place it on the buccal side as a veneer or a contour augmentation. And at the same time, we have got very good stability of these implants. Two angulated implants have been placed in the posterior, and two anterior straight axial implants has been placed. So we go for a temporary restoration. This is how patient looks the next day with the temporary restoration. This is the X-ray immediately. And what you see here, this is a transsinus implant where to get the good AP spread, the posterior implant here goes through the sinus wall on the anterior wall of the sinus, which is going through that. And you will see, because we use osteodensification drills, this lateral wall of the anterior wall of the sinus, it is pushed away. It is not that the implant is exposed to the sinus. It is pushed with autogenous bone. And as it heals, you will see the bone formation taking place in this zone. So this is after 4 months, once the implant has healed, patient has come back for doing the final restoration. And you can see here the final restoration which has been given to the patient. Now this is the smile, and you can see how she has ended up. And this is almost 2.5 years follow-up. And you can see that sinus floor moved completely away, and we have so much of bone formation in that region. So this is all-on-4, classic all-on-4 tilted implant technique, where we have used, where we have bone in A and B position. Another case, in the upper, we have tried to place 6 implants. In the mandible, we have placed all-on-4 concepts. As I told, upper, I always prefer, if you have good amount of bone, try to place as many implants as possible. In the mandible, as I told, that the posterior tilted implants are basically determined by the position of the mental foramen. So here we place 2 actually placed implants in the anterior mandible, and in the posterior mandible we have placed angulated or tilted implants, missing the mental foramen to avoid, but the head of the implant is just over the mental foramen. And this is how the prosthesis is done. And again, you can see this is a Polo-Molo type of bridge. You can see on the upper, this is our crestal sinus lift, which has been done in the posterior, and we have the implant exactly in the region of 6, so we don't have a big cantilever which needs to be done. So this is how it looks, and you can see a happy patient. Now, the best part about this is both this gentleman, and the lady you saw earlier happens to be husband-wife. And first I treated this case, and later he brought his wife to be treated. Now, another case where the lower anterior teeth are there, which is already, in a bad condition. Posteriorly, very less vertical height of bone is there. So we are going to do a full arch restoration for lower, and upper we are just going to place some implants and do a prosthetic rehabilitation of the teeth, what is existing. So we have removed all the teeth. This is not because of periodontal disease, so we can go for an immediate implant placement. So we remove the teeth, and we place the anterior implant. You can see they're actually placed, and posterior implants are tilted implants. And this is where it is exactly indicated. Posterior, we don't have bone. So there is, the only option is to do a tilted implant, and it has a very good success rate for long-term therapy. So what we do here is something called as intraoral welding. So once we place a temporary abutments, we are going to weld it, take it out from the patient's mouth, again put it in the cast, and re-weld all from the buccal and palatal aspects, so that the denture which is going to come out is going to be very rigid, and it will not break in the long-term provisional restoration, especially if the patient is from far-off place. So this is the provisional restoration, which is, you can see those welded bars, and you can see the intaglio surface of the restoration is nice and smooth. Always design this surface, the underneath surface, very well, because you need to have either a flat ridge or a ridge which doesn't have any kind of concavity, where your accumulation of plaque can take place. Your final restoration should be either flat or it should be convex, which goes into the ridge. So you can see here the temporary which is given to the patient, and we did some implants in the maxilla here, and she went for full mouth rehabilitation. And this is how we ended. This is the final restoration, and you can see here in this case we have done an FP1 type of restoration because there is not much loss of bone which has taken place. We could place the implant in the right position, so we don't have to restore the soft tissue or the bone which is missing here. The bone is not missing. That is why we could give this kind of restoration. This is how she finally left us. And this is 2 years later. You can see beautiful bone maintenance of all the implants, and restoration looks good. Now, a full arch bridge, again, as I told, not always we think of doing all on fours. So you are here again, you can see very less bone in the posterior, but I have sufficient bone here to give tilted implants and place uh, 3 implants in the anterior zone. So there are some implants here which have peri-implantitis which need to be removed. So I remove all the implants, teeth, and then later on we do the implants. Again, as I told, place the implant palatal and did some grafting, and then the temporary restoration is placed immediately. And when the patient comes, you can see the soft tissue. This is what we want to have, where you have a very, very good soft tissue profile for the final restoration, which either is flat or you have a slightly convex on the restoration. And this is how it looks. Again, the intaglio make it as flat as possible so that patient can maintain it. And this is the final restoration. And you can see there is 6 implants which is there, with 2 tilted implant in the posterior which is placed. So the more number of implant is always better when you do this kind of restoration in the maxilla, because the bone quality is soft. It is always good to have more number of implants. And this is how a patient has left us. Now, one more case. This is a case where there is very, very thin bone in all the areas. All the areas, there was very thin bone. This area had very, very thin bone, which required aggressive bone grafting. Patient was not ready for that. So we decided to do a conventional bridge in this area and lower arch for all the lower teeth, which was completely caries and decayed. We thought of removing it and restoring it with the implant-supported restoration. So we removed the teeth, placed anterior axial implants, posterior angulated implant, and give a temporary, and this is how it healed. You can see good keratinized tissue. And this is what we do. What we do is take out the temporary, and we can use this to do our final cast. And the vertical relation can be captured on the using a bite from the temporary, send it to the lab. So they make a putty index of this temporary and do the final restoration like this. And this is how the final restoration looks. This is how the patient was sent with upper conventional restoration and a lower implant restoration. Unfortunately, we don't have a very good OPG because the patient is a Malaysian patient, and she had taken a picture after 2 years. She was told to take a OPG, so she took a picture and sent it to WhatsApp. Now, other way of doing these full arch cases is today guided surgery, where we use our CT scan data to do computer planning. And from the computer planning, we derive the 3D printed stent, and we use this 3D printed stent to be placed. And this is a 2-part stent where the upper part is denture, which is printed, which goes exactly and occludes with the lower teeth, so that we can position the first part. This is the first part of the denture. So this will be positioned in ideal place, basically because otherwise we don't know the position how it is going to sit. So we are going to position it using the denture which is printed, which has occlusion with the lower denture. So we place the implant through the guide. We have these holes through which we drill and place our implants. And remember one thing, not always all the guides need to be flapless. If you have good keratinized tissue, good bone, then it is flapless. Otherwise, what we do is we do a pilot hole, we open the flap, get our implants in the right prosthetic position using the surgical planning, what we did in the computer planning, and then reflect the flap, place the implant, do the grafting, and save the keratinized tissue if you do not have sufficient keratinized tissue. Now, it is not always you get this kind of results. Sometimes we end up with complications. Sometimes we end up having patients which can cause complication. Now, if you see this patient, the patient is a classic class 3 patient. So we try to avoid collapse of the ridge. We did some socket shield and waited for it to heal. And we placed implants in other areas so that we can manage to hold the ridge bulk. And we did an all-on-4 procedure. But after 2 months after loading, we saw that the implant, one of the angulated implant failed. So we went ahead, placed another implant in that region, and did the second stage, and did the bite registration, temporary your teeth trial. And as I told you, always it is not necessary that we have to give a fixed restoration on an all-on-4 or an all-on-6. Here, what we are doing is we are going to do a removable restoration because the patient's teeth relation to be given, we need we will have a large cantilever buckle if you do a fixed restoration. So we went ahead with the bar attachment with the precision attachment for retention, and you can see this is the restoration what we have given, and this is how it looks, and this is how it looks in the patient's mouth. Now, for the final case, when there is complete atrophy of the maxilla, we might have to go in for something called as zygomatic implants. So in patients like this, you will see there is hardly 4 to 5 millimeter bone which is available in the anterior maxilla. Posteriorly, nothing there. In zone 2, zone 3, nothing is there. In the premolar zone, no bone. Molar zone, no bone. So we are forced to place zygomatic implants in such patients. So you can see in the anterior zone how much bone is there, hardly around 4 millimeters of bone. Because it is a basal band, we have good width there at least to place those implants. So what we can do here in the anterior zone to place some implants is something called as nasal floor lifting procedure, where we lift the nasal floor and place an implant into the nasal floor so that we can get in good length of the implant, and we graft that region. So we basically something similar to sinus lift. We do the nasal lift, and you can see now we have a good height which is available to place our implants in the anterior zone. In the posterior zone, we go for zygomatic implants, which are very long implant, which goes to the zygomatic bone, and it is a bicortical kind of a stabilization, especially in this case. And you can see we managed to place 4 implants in the anterior, and we have done grafting into the nasal floor. As you can see here, we have put graft because all the implants in the nasal floor is exposed. So we put the graft there, we put some graft in the anterior side so that we have good labial bone and cover it with membrane. And then we suture it up. All our multi-units are exposed, and we also place a pterygoid implant here. This was one of the cases I treated with Dr. Amol, prosthodontist of Pune. And you can see here 3 implants in the nasal floor. It is all healing well. Immediate loading, we took only the anterior implants and the pterygoid implant. We left it so that once it gets integrated, we can load it with the final restoration. This is the temporary what we give. Again, as I told, your intaglio surface should be very, very good, well designed. And this is the final restoration, and this is the final result what we have achieved. And in the lower arch, you can see a classic all-on-4 which has been done. So, in summary, when you talk about doing in full arch case, it is not that all the cases what we see, we are going to treat it in the same way. We need to choose our technique which will provide maximum function to the patient and aesthetic needs of the patient. And it depends also what is the age of the patient, what you're dealing with, what is the patient's needs and the aesthetic requirements. A younger patient, as I told, will always has higher demand for aesthetics. It also depends on the lip support, the lip line, what the patient has. So what is the technique you will choose? What is the type of prosthesis you will choose? Everything is to be predetermined. So you need to do a lot of work on your treatment planning. So it is not necessary, as many people think, tilted implant is always graftless. You would have seen in many of my cases, the tilted implant also received some graft on the labial side, because I know that if I don't graft when the bone is thin on the labial side, I will lose that bone and I will have implant exposure. Especially when you have less number of implant, if you have bone loss on those implants, you will struggle in a long run. So graftless might not be graftless all the time. So if needed, tilted implant philosophy can be used with the grafting principles. So treatment planning is the key. You have to have a proper flow for your treatment. And according to me, the future in this particular is completely a digital workflow, as we have still not caught up with the digital workflow in India. We have a lot of guided surgery, what we are doing, as I showed in one case. But when it comes to the prosthetic digital flow, we still are lacking. Our labs are getting accustomed to it, because the transfer of information from the clinician to the lab is where it is lacking, even though the lab already using a lot of digital technology. With this, I would conclude my lecture on this full march implant therapy for different types of patients. Thank you, one and all, for a patient listening. And I hope that this crazy time ends and we will all go back and start our clinical work. Stay home and stay safe. Have a good day.
Okay. Thank you, sir, for excellent deliberation, unique cases, and unique pictures of the patients which you have shown. Now, there are many questions. Many questions from the viewers. Dr. Abhijit Mohanty from Bhubaneswar, he is asking, how long can a transitional denture with intraoral oral welded reinforcement last in patient's mouth? Any issues? Any issues if it lasts long? Any issues? This has a long-term transitional prosthesis.
Yeah, it lasts basically whenever it is more than 6 months. If the patient is not returning back to me, I want to have a denture which will not break. See, what happens is, if the denture is only a denture conversion, what we do, and if it is not very thick, there is chances that when the patient is away, if the denture breaks, and now the implant is loaded, if it breaks in between one of this implant, that means one side of the implant, maybe only one implant will be loaded there. So what happens is, the chances of failure of that implant, which is completely loaded, will increase. So because of which, anything what I do for more than 4 months and the patient lives far away from my place, so I go for an intraorally welded technique. I pick them up and send it to the lab, and he does the hybrid, denture conversion and sends me back. And these kind of restoration, I have seen that it lasts almost 1 year without any breakage.
Okay, thank you, sir. Dr. Ambrish from Nagpur, he is asking, if cortical bone is very hard, then we can use a densa burrs or a conventional burrs. Burrs are only the choice.
Now, the cortical bone, if it is in D1 bone, you never want to densify it. What we desire to have in our next to our implants is something called a D2 bone, that is an ideal bone. D1 bone is a very difficult bone to drill, so we need more sharper, and we don't want to densify anyway, so you can go with regular drills. For a D3 or a D4 bone, we always wanted to convert it into a D2 bone, because that gives a better bone to implant contact, and because of that, your integration is faster, and you can also have better primary stability. That means, as you see in my cases, I could load those spaces immediately, and the patient walks out with the denture the same day or the next day.
Okay. Dr. Ami Reddy from Hyderabad, she's asking, sir, are there any precautions to be followed during nasopalatine implant placement? as many vital structures will be encountered there.
Now, the thing is, the nasopalatine canal's main important component content, what is there, is incisive nerve, which comes out there. And the surface area, what it supplies, is very, very small. It is around 2 millimeter to 3 millimeter in size. So, even if you remove all the contents of that area, the patient is not going to have a significant neural disorder there or paresthesia there or anesthesia there, because patient cannot feel because the area is very small. The patient might have anesthesia unless you take a probe or a needle and pinpoint it, he will know that there is anesthesia or paresthesia. But otherwise, by itself, he cannot make out because the area is very small. So this is a technique which has been there and been used whenever there is atropic situation in the, especially when it comes to buccolingual width of the anterior maxilla. So this area, usually when you have a nasopalatine canal, you have good buccolingual width the moment you clear all the canal contents. So you can go ahead and use it. There are a lot of literature on this particular technique, which if you are interested, you can go and search and read about it.
Okay. Sir, Dr. Pankaj Mishra from Lucknow, he is asking, can we fix zirconia crown on posterior tooth or not?
You can use zirconia crown on the posterior. You can use, once the framework is zirconia, you can use, I prefer to use on a zirconia framework or a PEEP framework, I prefer to use a lithium disilicate crown because of the aesthetics it gives. But you can go ahead and do a layered zirconia even in the posterior, not a problem.
Okay. Dr. Rajendra from Jaipur is asking, indication for pterygoid implants in all on 4 titled implant. Should we should use in all cases for extra support or in some indications?
It is used in when there is less bone. On the host bone, what is available is less. In the anterior, you are placing implant in a grafted bone. It is always better to have a more number of implant. So what I would do is usually when, especially the case where you saw pterygoid, when the bone is very, very soft, when I know that there is chances of failure of this, some of the implant, I go for pterygoid implant because more the number of implant, better are my chances of long-term survival. So I take on that basis the number of implant, depending on the size of implant I place, depending on the quality of bone I am placing my implant in, and depending on the actual host vital bone which is available, not the grafted bone. So if you see one of the cases in the symptomatic patient, what I did was the anterior bone, what was there was the host bone, what was available only was 3 to 4 millimeter. That means even my 10 implant, the 6 is in the grafted bone. That means that grafted bone will take a very long time to turn over into a new bone. So that way, we need to increase for that long-term restoration, which will last for a very long time for the patient.
Okay. Dr. Lakshmi from Pune, she is asking, is there any contraindication for full mouth rehabilitation?
Full mouth rehabilitation, there is no contraindication as such, but there is medical contraindication which is there for any implants what you do. And we need to be taking care of that medical component of the patient taking long-term bisphosphonate therapy, patients who are uncontrolled diabetic, and all these patients need to be taken care before we take up such patient for full mouth implant rehabilitation. The most important also is patient who has bruxism. As I told, you need to, whenever there is bruxism, whenever you need to increase the number of implants, we need to increase the quality of bone, number of, and the type of screws what you use. It is always better to use a custom abutment which directly goes into the implant instead of a multi-unit, so that as the screw fractures, everything will be avoided.
Right. Dr. Rekha from Davangiri, she has 2 questions. Best combination of framework and teeth, and what precaution to be taken with zirconia framework?
Zirconia framework, now we have a good, literature which is with the 10 years of follow-up of zirconia restoration. And full monolithic zirconia frameworks has worked well, and it can be taken up, but peak with other material like lithium disilicate on top of which is still not doesn't have long term, that is more than 10 years what we need to see. So we will get all these new procedures, new materials require time to reach, the literature support where we can say, okay, this works for more than 10 years. So ideally, what my choice would be to is if the aesthetic demands is very high, I would choose depending on the vertical space available. If I have something around 12 to 15 millimeter, I would do a zirconia framework with the lithium disilicate Emax crowns or a peak framework with Emax crowns. If it is larger than that, if it is 15 to 18, either I go for hybrid or I do a peak framework with composite teeth on top of it.
Yeah. So many of our viewers are asking, they want to learn implantology from you. So how you can help
So
them
we
out?
have a course which is running in our college from the Implant Center, which is a ICUI fellowship course, which is a 1 year long course. So they can enroll to that course, and from our college website, they can get details on that course and contact the secretary of the office who will help them out in that.
Sure, sir. That's great. Sir, now there is one question which is related to COVID infection. Dr. Burman from Kolkata is asking, with the proper protective gears, how much safe is the implant, both for patient and doctor, as it generates the aerosol?
Yeah, that is always a question. Till third, I think we are having a restricted treatment where we are just seeing emergencies. We are not doing any implant patients or something like that. But after the restrictions are lifted, probably we need to be taking care for what kind of treatment we do, and probably we might go in for techniques where we'll do slow drilling without water irrigation so that the aerosol generated is less. Along with that, we also take care of reducing the content of virus in the aerosol by having a pre-procedural rinse with povidone iodine and hydrogen peroxide, and taking all the precautions of PPE and the N95 mask. Probably after the restrictions are removed, we might have to do with making sure that we generate less aerosol. And one of the ways of doing this is protocols of drilling where we don't use water for irrigation, doing a slow drilling protocol, or using magnetic mallet, which is an osteotome technique without any drilling protocol can be used.
Perfect, sir. Sir, we have answered almost all the questions of viewers. So with your permission, we can close the webinar now, sir.
Okay, thank you, everybody. Thank you, and stay safe.
Over to
Thank you for the Sun Pharmaceutical for organizing this event for everybody, and these are great gestures because when people are not having anything to do, it is good to sharpen your axe and make sure that you learn something new. When you go back, you know something which can be put on to use for your patients and benefit your patients. Thank you, everybody.
Yeah, over to Amit sir for vote of thanks and closing.
Yeah. Thank you, Dr. Tarun, for the excellent presentation you have made, and I'm sure that the viewers can going to be more benefited by seeing your presentation in their day-to-day work.
Thank you.
And this could be, at least said by you, this could be the one of the best thing to do with this COVID-19 era when people are at home, so they can sharpen their skills and knowledge.
Yes, that is the best thing. And thanks for the pharmaceutical companies, taking that effort to do all the things what is required. And it's great appreciation has to go to all of you.
Thank you, sir. And on behalf of Sun, I would like to thank the viewers, the audience, for making themselves available for this session. And Sun is also, always we are at a forefront of serving customers, serving nations, and we are there with the whole medical fraternity at this COVID-19 situation. And whatever, in a best way we could able to serve, we would like to give our assurance to serve you in a better way. Thanks again for your valuable presence. Thank you, sir.
Thank you very much, sir. Thank you very much, sir. Thank you.